Hello, everyone. My name is Brad Sutton. I'm Chief Medical Officer for AF Solutions at Boston Scientific. Thrilled today to be joined by Dr. Vivek Reddy, Professor of Medicine at Mount Sinai School of Medicine, to talk about the Advantage AF trial. Vivek, thanks for joining us.
Thanks for having me, Brad.
Can you tell the folks a little bit about what the trial design was, what we were investigating and hope to accomplish with the study?
Sure. So Advantage AF was looking at pulse field ablation using the pentaspline Fairwave catheter to try to treat patients with persistent AFib. It was a single-arm trial, but the design was that every patient gets both PV isolation plus posterior wall ablation. It's also important, this is a prospective multi-center trial. It's an FDA trial, so it was performed with all the typical monitoring that one has in FDA trials.
So we're a year into commercialization of the FARAPULSE system. People may forget that this trial was kicked off before FDA approval. We had a large number of centers in the study, but maybe just contextualize kind of where folks were in terms of their learning curve with the technology, what it meant to do posterior wall with this technology. What was your experience?
Yeah, I mean, and it's an important point because now there are a lot of pulse field ablation procedures being performed. But when this trial started, only about a third of the operators had any experience with this catheter, and that was in the Advent trial, the initial trial using of PVI only for paroxysmal patients. The remaining operators had no experience with this catheter. And in fact, the vast majority of the operators had no experience using this catheter for the posterior wall. It's also important, I think there were almost 80 operators in the trial, which is very unusual for an FDA trial like this. So and it wasn't that all the procedures were done by a few operators. This was spread across the whole experience. So I think that's an interesting aspect of the trial that we need to delve into.
And then in terms of the results, obviously we met our primary efficacy and safety goals. If you could just walk us through a little bit about what the results were and what they mean to the kind of clinical community.
Well, if we look at the safety outcome, we did meet them. And importantly, the kind of complications we worry about with AF ablation, fistula, stroke, tamponade, these things did not happen in this trial. And I think that's a very important point. The few complications that did occur, and I think there were a total of 7 of them, there were things like pulmonary edema and things that I think we're pretty happy about. On the efficacy side, the overall success rate was 64%. This 1 year freedom from atrial arrhythmias, redo ablation, drugs, et cetera. And so 64% is reasonable. But I think what's really striking is when you look at the outcome as a function of the number of cases. So if you look at the first 3 cases done by any operator, and 3 because that was the median number of cases, versus all additional cases done, there was a dramatic improvement. So it went up by 10 plus points in terms of effectiveness. The other interesting thing is, if you look at the failures, again, these are patients with persistent AFib, the vast majority of the failures, the patients had only 1 recurrence. In fact, the actual redo rate, which gives you some idea of how bad the recurrences were, was less than 5%. So I think overall, this speaks very well, given, again, this is the initial introduction of the technology for these operators. And, it'd be really interesting to repeat the trial with the same operators now that they've done a number of cases.
Yeah, it's amazing. I mean, I think the learning curve we've learned with this technology, this catheter is very short, in general, reproducible. I think it was something on the order of 15, 16 minutes to isolate the posterior wall, ablate the entire posterior wall, which is pretty amazing. I want to maybe circle back to just this rhythm burden story and what that means for patients. Of course, we're trying to make patients' lives better, symptoms better, quality of life better. I was also struck by the fact that there were so few reablations over the course of the year. What can you sort of say about the calculated rhythm burden and how that sort of impacted, hospitalizations, quality of life, things like that?
Yeah, I think that's really important. I think one of the things we're learning is that burden tracks with outcomes, with clinical outcomes, with how patients feel, et cetera. And so we did do a burden calculation. We didn't have loop recorders in these patients, but we could still calculate based on intermittent monitoring. And what we see is that about 65% of the patients had less than 0.1% burden, and a little over 80% of the patients had less than 10% burden. So it's really the exception of these persistent patients that had a lot of burden. And it's important because particularly at the 10% cutoff, it turns out that those patients that had less than 10% burden had the greatest benefit in terms of quality of life improvement, which was quite substantial, and also had the least healthcare utilization, cardioversion, redo ablation, hospitalizations, et cetera.
Is there, we're obviously running a trial called Avant-Garde, which is a bit different from this in that they're first-line persistent AF patients. If you think about sort of the future of ablating persistent AF, what does this trial do to move the field forward, and where would you go from here?
Yeah, a couple of things. First, I think what this trial shows you is that you can safely, efficiently, and effectively perform a PVI plus posterior wall procedure that treats the vast majority of persistent patients. Avant-Garde is very interesting because it is a randomized trial looking at first-line ablation versus medication. So that, I think, has tremendous potential and I fully expect that it'll be positive, but we'll see what the trial shows. In terms of next steps, I think there are a number of questions people have. It'll be important to understand now that operators are getting clinical experience, what are the outcomes once you're past your learning curve? Second, there have been a lot of enhancements to the technology, whether it's introduction of electron-anatomical mapping, indexing, whatever. And it'll be important also to understand once you add these little enhancements, and some of which are not so little, you may see another increment in success. And finally, I would say that, phase 2 of Advantage, because there was a second phase where patients had implantable loop recorders, so another cohort of patients. We're hoping to see that data later this year, and I think that will be another really interesting data set with implantable loop recorders.
Yeah, really good insights. I want to thank you for your commentary, your presentation today, and your insights on the study. Appreciate it.
Thank you.